everyone. Welcome to the MMOA podcast. My name is Shelby Blankenship. I am one of your TAs and physical therapists. And today we're going to be talking about blood pressure and how to individualize blood pressure measurements. So this is a topic that kind of gets brought up a lot of how to manage blood pressure, especially when it comes to exercise, especially with the parameters that we have and guidelines that we have from medical doctors. So we're just going to kind of talk through some scenarios of what I have personally done in my clinical practice. Please know this is all we call level 5 evidence. So I have no medical papers to kind of back me up on this, but this is just what I have found clinically to be really meaningful, and some just things that I would be mindful of in your own practice, regardless if you're in acute care all the way through outpatient or doing home health. So a couple things we're going to go through is managing people's symptoms, their medications, and then the intensity of the activity that you're doing, as well as, how that's going to be managed with what you're seeing from the client. So I'm going to give you kind of two different stories and the two different scenarios of like what we did. So one individual I have, he is in his mid to late 80s. He's got pretty severe vascular dementia, and he has been coming to see me over the past year off and on due to these episodes that his wife would describe as knee buckling. So he'll just randomly be standing or walking around. He'll be standing, maybe for a few minutes, maybe immediately, and his legs will give out. He becomes incoherent. Very similar symptoms to someone who has orthostatic hypotension, except it can be very delayed. So what we have noticed with this individual is that when this has actually happened in clinic and at home. So it's been nice to kind of see, how he does. It doesn't, because sometimes it initially was just happening at home. So we actually got to experience this when he was trying to come into the clinic. He had an episode out in the parking lot. So I was able to go help him take his vitals immediately. And we were kind of able to help create more of a narrative that I could talk to his doctor about to try to edit some things. So for him, when he has a blood pressure that's pretty much 120 or under for his SPB, sorry, his systolic, that is when he is having symptoms. So if it's 120 or under, he has this dizziness and he really struggles on staying coherent. And, but we've noticed that if his blood pressure at starting is between 140 to like 165, he is fine, totally good to go, has no issues, especially with exercise. It stays pretty consistent. Overall, his heart rate stays in the upper 50s, lower 60s, just like at rest or at baseline. The highest it's ever gotten in here is maybe mid 70s, maybe low 80s at the most. And he works really, really hard, but he also has a long history of some heart issues. So his heart just does not accommodate exercise as far as symptomatically, with his heart rate vitals that you see. So a lot of it is his blood pressure is really the biggest metric of what we can kind of see intensity wise. But I think it's really interesting because I know a lot of people learn basically anything 120 over 80 is kind of like where we're shooting for. And I've really found, especially with some of my older adults, that they actually do better sometimes when their blood pressure is a little bit higher before they start doing exercise. It's almost kind of like we did a podcast earlier about blood sugar, and especially with my husband who has type 1 diabetes, he has to actually have to start with his blood sugar much higher than like you or I would. And it's similar when I see individuals like him, where if his blood pressure is not higher, he really, really struggles, especially if we're doing a lot of functional lifting. such as like deadlifts and sit to stands. And part of that for sure is like the orthostatics that goes into it. But he just like overall will struggle with maintaining that baseline to stay active during the session. So there have been times where, for example, that time I was referencing before, where he was in the car, he got out of the car, his wife was helping him in, and immediately he had a knee buckling episode. I ran out there to help her, and he was incoherent, was death gripping the walker, very similar to most orthostatics that I've seen, and would not respond to any commands. Within about 1 minute, he was responding to commands again, and he was obviously a little bit confused about what happened, but we were able to get him inside. We took his blood pressure, and it was around 110 over 55. So we started with some seated TheraX just to try and get his blood pressure up, because I knew that if we did a bunch of standing, he probably was going to have another episode, which not only frustrates him, but also frustrates his wife, seeing like his legs just give out underneath him. So we started with some seated TheraX with band exercise, trying to get that blood pump, try to get that intensity up. We did about 3 to 5 rounds of like banded leg press and like chest press, banded rows. We did even seated deadlifts, and he was totally fine with all those. I was trying to get the bigger muscle groups to get a bigger pump to kind of go throughout the whole body. And after we did both of those exercises, his blood pressure raised to about 120 over 60. And so we tried to do some standing, and he did fine. He didn't have any episodes, but it was still on the lower end for him. So we just kind of kept that in mind. From there on out, we had a discussion with his wife about making sure to monitor his blood pressure. But it was also noted that he really, really struggles with dehydration. And part of that is because, one, he just doesn't have that thirst sensation. But second is he has issues with incontinence, and more specifically functional incontinence. So in his mind, if I restrict water intake, I restrict the opportunity to have to go to the bathroom, have to rush, have to have an accident of some sort. So he has self-created a little bit of a problem when it comes to managing his blood pressure, because he's so dehydrated. His blood pressure is having a hard time keeping up and staying up. So that's another conversation that we had. The next thing that we did going into that medication management is we obviously reviewed his medications, and I had a conversation with his doctor about if there were any opportunities to modify or like as far as like the type / the dosage, because this was kind of an ongoing process, and they actually were able to take him off a certain med and put him on a different one, which was very helpful. And the episodes actually drastically decreased, but it was still noted like the dehydration was a really big component. So just kind of keeping that in mind, like just because somebody's having some of these blood pressure issues, it's not always the blood pressure medication that could be the problem. There could be other issues, especially when it comes to hydration, especially with this population. The next thing that we did is, we talked about modifying the intensity. So we modified the intensity that day with the seated exercise. And then on our other sessions, when his blood pressure is 140 over 70 or in the 150s, 160s, et cetera, we're doing all standing exercises. So he's able to get that stimulus that we need to make sure that he's getting the intensity that we want, which he honestly doesn't really tend to have his blood pressure be super elevated after exercise, but he does tend to have the more just like overall fatigue. So we kind of have to modulate that to make sure he's not getting overly fatigued so he can't do what he needs to do at home. So just to recap that first case, older adult, mid to late 80s, pretty severe vascular dementia. He had some heart issues in the past that we have addressed, but his biggest issue that he was having these knee buckling episodes, and we were able to kind of relate those to his blood pressure dropping too severely. And that was unfortunately, like what we would consider the norm of doing like 110 to 120 was too low for him. So we actually had to bump his blood pressure to being more of that 140, 170 threshold, and that he tends to do much better with that as far as activity goes, especially in standing. Now we're going to go to a second case. This is for an individual who actually had really high blood pressure and did not do well in that blood pressure camp. So this was a lady, she was in her mid-60s, had a previous history of multiple strokes, pretty poor insight as far as taking her meds, just overall like health in general. So I was seeing her for just like general strengthening, trying to get that left side stronger. And she would be completely asymptomatic and her blood pressure would be like 220 over 110. Now, this is where it gets really, really hard because they, especially if they've been in and out of the hospital system, they're like, I do not want to go back, right? Like they don't want to go back. They've had either a good or bad experience, but from a cost perspective, they don't want to go back, et cetera, et cetera. So we had a few times where she came in. We always took her blood pressure before we ever started just to see, where we're at from a baseline perspective. And she was notorious for forgetting to take her meds. So that was another reason why we always took it. But when she had so the first time she had 220 over 110, I immediately called her doctor and asked for his recommendations because of her long history of ischemic stroke. And he told her to immediately needed to go to the ER. So we did that. That was scenario one. Next scenario, she came back. Again, it was 210 over like 100. So a little bit better, but not that great. And again, she said she had taken her blood pressure meds this time. And we were like, okay, this is what we're going to do. We're going to have her do like 5 to 10 sit to stands, just see if we can get some perfusion throughout the body and see if maybe that makes any changes. Again, that is something she would have to do regardless of getting in and out of the car, going to and from the toilet. Like it's not something that I would say should be like a high intensity because relatively speaking, she was moving around like with like standby contact guard assist. So we had her do that, took her blood pressure again, and it was 185 over 95. So going in the right direction. So we just repeated that cycle and we did that multiple times. And we've actually did get it down to about 165 over 90, which again is pretty high for a blood pressure baseline. And I did call her doctor again to have that conversation of like, hey, we might need to change blood pressure meds. Something is going on. And come to find out, she has also got really, really bad seasonal allergies. So her seasonal allergy medicine was interacting with her blood pressure to keep it elevated. And her blood pressure medicine was just not strong enough to handle the load that she was, that it was requiring. So that's another situation where you're kind of have to be very mindful. And honestly, it depends on the patient in front of you. Again, this is level 5 evidence. So don't always use this for like every person that walks in your door, but just be mindful that just because their blood pressure is not like 120 over 1 or over 80 doesn't mean you can't work with them. It means you need to have clinical judgment and clinical reasoning of what to do next. And sometimes that's working with them, sometimes that's not. You have to just be mindful that some people just sit at that 140 over 140 to 150 and do fine, like that's their norm. And some people are completely asymptomatic in that 220 to 110, which could be, obviously a very big deal depending on what they got going on, especially if they've had a history of stroke. So going back to kind of like that three pillar thing that we were talking about, symptoms. Make sure just because somebody is symptomatic or asymptomatic, you always want to check blood pressure or all the vitals in general, but especially blood pressure. It is one that is super commonly missed. And it is a great indicator of kind of like where they're at for that day, and be monitoring it over and over and over again every time you see them, so that when they do have these episodes of 170 over 100, if you've never been checking it before, it might make you panic a little bit. But honestly, if you knew like, oh, they always are around 160s, then it makes you think, okay, well, let's just see what they do with blah, blah, blah. And then you can have a little bit better insight instead of just constantly sending people out the door to the ER. That's just unfortunately not going to work. 2, be mindful of meds. Make sure you have a medication list when people check in, and be mindful of like, hey, what other things could be affecting the meds or limiting their capacity to be effective. From one of my guys, it was the dehydration issue. For the other lady, it was her allergy medicine was really messing with her. And the third is monitoring blood pressure almost like you do blood sugar. Sometimes some people need to start at a little bit of a higher level to make sure that they're not dropping too low, just because they tend to be more prone to that kind of orthostatic hypotension type of situation, where it's not exactly orthostatic hypotension, but they just tend to drop with exercise, and then they tend to have issues with the knee buckling or that kind of incoherent symptom. But those kinds of things can be super helpful to make sure you're, one, using your clinical judgment, but two, making those patients aware that not only are you going to be monitoring their blood pressure, but they need to monitor at home as well. It's super, super helpful when you notice that pattern, like I did with that one guy, so that you can have those conversations with the medical doctor, because they don't see that as often as we do, and they can't always articulate or see those patterns of when those episodes are happening, so that you can actually give them a little bit more freedom when it comes to exercise and how and what they can do at home without feeling like every time I get up, blah, blah, blah is going to happen. Or every time I, get up, walk to the door, go to church and do all these things, by the end, like my blood pressure is tanked and I've got nothing left in the tank. So just kind of be mindful of those things. They can be super helpful, not only from clinical judgment, but also educating your patient on what their blood pressure is doing and how it does with you when doing exercise, especially with high intensity intervals. Just to kind of go over what MMOA things we have going on. So this coming weekend, April 20th, we are doing 2 live courses, one in Hendersonville here at Stave Off, which we're super excited about, and then another one in Aspinwall, Pennsylvania. L1 will be starting May 15th. And L2 will be starting the next day on May 16th. If you want any other live classes, the next one is not until May 18th, which will be in Richmond, Virginia and Bismarck, North Dakota. I hope this was helpful for you guys. If there is anything that you guys would like to learn more about, please comment here below so that we can keep up to date with all the evidence, but also give you the things that you guys want. Hope you all have a great day. Thanks so much.